and it is a privilege to moderate this panel. And of course, this is a critical moment as we contemplate today the intersection of addiction treatment and behavioral health. It's a pleasure to join you today. We want to just introduce today's discussion with some context. Next slide. We have understood the opioid epidemic as having three main points of inflection, beginning in the late 1990s with the increased advertising for prescription opioids and the emphasis on pain as the fifth vital sign that there was a wave of prescription opioid-related misuse and overprescribing that occurred at that time. And so that was primarily responsible for the first wave of the opioid epidemic. The second point of inflection was in the 2000s when we learned that a transition to heroin use was occurring across the country. And we also all are aware of that seminal article that identified for the first time the American life expectancy was on the decline. And we believed at that time that we had entered what is called the epidemic of hopelessness, where more individuals were dying of behavioral health related needs, addiction, suicide, or overdose. And finally, in 2013, we identified the fentanyl-related crisis that was associated with synthetic opioids. And we know that especially in the District of Columbia, the last report I received is that we have had a 45% increase in opioid overdoses since last year, and that over 95% of those are driven by synthetic opioid overdoses. Next slide. And so we recall that in 2016, the U.S. Surgeon General issued a historic letter to 2 million providers across the country asking us to evaluate our practice when it comes to particularly pain management. Next slide. We also know from the National Institute of Drug Abuse that actually most individuals with pain syndromes do not misuse opioids. In fact, the numbers that they provided is that roughly 20 to 29% of patients who are prescribed opioids for pain misuse them. They also found that an estimated 8 to 12% of people who use opioids for pain go on to develop an opioid use disorder. In addition, an estimated 4 to 6% who misuse prescription opioids transition to heroin. Next slide. We also are aware that racism has to be acknowledged when we think about how issues of pain and addiction are addressed. Sadly, the Association of American Medical Colleges has found that half of current medical trainees who are white still believe racist myths about biological inferiority of Black people. They still believe that Black people are more immune to pain. And in fact, this is perpetuating some of the inequities in terms of how pain is addressed. JAMA Psychiatry also acknowledged that when we think about the intersection of opioid use disorder with this matter, that in fact, buprenorphine prescriptions are concentrated among people of privilege, people who are white, college educated, and live in suburban areas. In fact, Black patients are 77% lower odds of having an office visit that included a buprenorphine prescription. So we have a vast problem right now when it comes to both assessing these issues and responding and treating them. Next slide. And so the National Institute of Health, as well as Health and Human Services, have identified key priorities for how to tackle this problem. They have identified a need to improve access to services, to promote the use of life-saving overdose reversing drugs, We have to strengthen our understanding of the epidemic and specifically its impact on vulnerable communities. We have to provide support for cutting edge research on pain and addiction, as well as advancing best practices. Next slide. And so with that context, today's conversation is really about discussing current practice methods for addressing chronic pain, opioid use, and mental illness. Our panelists today will address risk factors and treatment options to discuss specifically the role that trauma plays in mental illness and what providers can do to mitigate trauma risk in their patients. This auspicious panel will also further discuss creative solutions to the unique challenges facing caregivers. As we understand, we're not only in a COVID-19 pandemic, we're also in the midst of an opioid and a racism pandemic, and all of those issues must be addressed. And so we will hear today how communities of color are also disproportionately affected by pain, opioid use, and behavioral health disorders, specifically the chronicity of those disorders. And together we will hope to shed some light on innovative strategies to achieve optimal patient care and outcomes. And so with that, I would like to transition to our first question. I would like to begin with Dr. Richards. Can you describe your contribution to the spectrum of care in regard to these issues?
Thank you, Dr. Madlock, for such an all-encompassing introduction, because there's so much to unpack moving forward. And when I think about specifically the role that I play now, my contribution is in the bigger sense related to what we do to support people once they reach the level of inpatient admission. And we'll talk throughout the hour about dual diagnosis. And when we hear the dual diagnosis, of course, we're talking about not only the substance use disorders, but also mental health and where is that intersection. And as a psychiatrist at Sibley Hospital, then what we try to do is severalfold, but most of the time we see people hit the hospital, it's because they're in crisis. And the crisis is severalfold. One is a lot of times they are trying to start on the path, perhaps for treatment. But in order to move down that path for treatment, we have to look at different aspects. And I like to say we look at 4 different things when we're talking about the mental health of someone. One, of course, is the diagnosis. What are we talking about? Certainly substance use disorders are involved, but also, is there an underlying depression? Is there an underlying anxiety? Is there bipolar disorder? And identifying that matters, because we then have to talk about how we can support someone in their role for treatment. So there's looking at the disease, there's looking at what I call someone's life story. What brought them here today? What is happening? Did they lose their job? Are they arguing with family members? Are they desperate? Are they looking at kind of the racial injustice and trying to find an escape? So there's so many things to look at in terms of that life story piece. Then we have to address, the behaviors in different ways, one of which is actually talking about the substance use disorder and how we can talk about that. And the fourth, of course, is the personality of the person. How can we talk to them? Is it motivational interviewing? How are we going to discuss what these next steps are? So on the inpatient unit, we try to assess people for all of these aspects, because we know that the way they fit together is so important for addressing things moving forward.
Thank you, Dr. Richards. That was a great framework to get us started. Dr. Cartwright, you have some experience in pediatric populations in regard to these issues. Can you share with us how you contribute to the spectrum of care?
So during the early parts of the day, I'm the medical director over at United Medical Center. Many times we see the larger number of folks who are coming to us are persons who are involuntarily admitted. So these are persons where the behaviors are to the extent where the authorities are involved. And sometimes the person is doing so poorly, their insight really is impaired. And so when they come to us, they really are not in the best of places psychiatrically. And so that, when you see those persons at that point in an adult hospital, you also have to recognize that some of them may have children at home. And so I'm also a child psychiatrist. And on an outpatient basis, the children that we see, when the parents have a substance use disorder, it's very difficult for those children to form attachments to the parents that are secure. And many times you may see concurrent psychiatric illness that sort of mirror the difficulty that the parent may be having. And so particularly with the pandemic, what we've seen is as the parents struggle, the children too are in crisis. And the question becomes, how do you support those children, but also help the parents? Because again, remember, a lot of the persons coming to us are persons who are involuntary. So how do you get the parent to be able to move to a point where they begin to see that there is an issue that they need to address? Because they have people who are depending on them, but they also have to figure out how do they take care of themselves. And so when you see the intersection of financial struggles, the pandemic, having to manage children at home, being stressed out, and the stress of the pandemic affecting things like relationships, marriages, the education of the children, it really has put a lot of strain on the families. And even some of the little kids will say to me sometime, like, I just want to go to school. I just want to see my friends. And so when you look at the impact that the opiate crisis in conjunction with the pandemic, that has had on family and children, it has really been quite significant.
Absolutely. And you have emphasized, thank you, Dr. Cartwright, the importance of having a team-based approach as we think about these issues. And so I want to transition to Dr. Petit, who is currently practicing in a team-based model. Dr. Petit, can you share with us how we address these issues? Dr. Richards has highlighted needs among adults. Dr. Cartwright has shared the needs with families. So how do we address these issues as a healthcare team?
Right. Well, basically, as the addiction medicine fellow, like you mentioned, I'm part of the team that involves peer recovery coaching, psychiatry, psychology, as well as case management, primarily through the Urban Health Initiative. So I see patients, from the emergency room to the inpatient detox unit, and follow them to our outpatient treatment program. And then from there, I titrate medications for opioid use disorder or alcohol use disorder, provide motivational interviewing. And during that relationship building period, we can get a better idea of their additional needs and connect them with, like I mentioned, case management. Primarily, the Urban Health Initiative has done a really, really good job in helping patients stay into treatment. If patients fall out of treatment, they bring them in, they call them, and so forth. If they miss an appointment for a prescription, they get a hold of me really quickly. A lot of times you learn from that, the kind of just struggles that they're having with childcare and so forth. So you get a really good picture of what's going on and the challenges that may precipitate a relapse in these individuals. So that's really how the care model kind of works. We all work as a team and communicate consistently on patients. So each patient has I would say about 4 or 5 people that's around them to support them through their recovery.
Thank you, Dr. Petit. It sounds like a dynamic team approach that you are using there at the Howard University Clinic. Dr. Manalai, you are the Director of Addiction Services at the Psychiatric Institute of Washington. Can you share how your team is contributing to the spectrum of care? Dr. Manalai, we just need you to come off mute.
Can you hear me now?
Yes.
Okay. First of all, good to see you again and good to see everyone else there. I think we are in a unique position. We kind of combine what Dr. Richards and Dr. Cartwright said in PIW. So we have services that are voluntary and services that are court mandated at times. In the combination of sometimes quote unquote pure substance use disorder, although very rarely you would see them purely, it's most of the time co-occurring disorders. And we care for the most disadvantaged and ignored population in the city. Being the largest inpatient psychiatric facility, we have larger numbers of patients, and fortunately, we have in the position to provide care for those individuals that probably most ignored in other systems, which has been a pleasure personally for me. Our patients are usually grateful, and the way they express it makes our job, although it's very difficult, highly enjoyable. So our role is to kind of see, can we break the cycle of, I would use that pejorative term, but I think it is appropriate to use in this video, treat them and street them. So it's the recidivism is to a degree expected. The risk reduction approach would be to reduce that, but at least some people may or may not be able to sustain in the community. So there's some recidivism, but in what way we could support our patients to reduce that recidivism, and also to break that cycle of going in and out of the hospital, which, for example, when they are using opiates and they're quote unquote complete with the detox and go back to the community, if they use, probably it would put them at higher risk for unintentional overdose. The same amount that they were using at this point after 5, 6, 7, 10 days may actually be lethal by that time. So the way we look at it, at least our goal is to become a transitional point between when patients come and hopefully get them connected to programs like Howard. We do ask our patients to go to Howard, the buprenorphine maintenance program. They have wonderful program that patients can walk in. I think both of us have been part of that program at some point in our career, and also to transition them from inpatient to some sort of structured environment, the 28-day rehabilitation program. And we are fortunate that we partner with a medical group home, that they have been very gracious. When we have patients that are highly motivated, they could actually leave with a prescription, for example, for Subutex.
Thank you, Dr. Manilal. You said something that is so critical, that we are caring for some of the most marginalized populations in our society. And I want us to tackle that point next, this idea of structural vulnerability, that often the threats to one's health exist in the community in terms of economic resources, trauma that has been experienced, history, et cetera. And so I want our panelists to tackle this as we think about the history of marginalization, specifically of trauma. How does that impact this issue, especially substance use? I want to go to Dr. Cartwright first and ask for her to share with us what is the impact of adverse childhood events as they relate to trauma and addiction?
Well, when you take a look at primary things, if you think about, for example, Erik Erikson and life cycle theory, and you start to look at phases of life and experiences that kids will have from the time of birth as they get to their teenage years and then transition into adulthood. When you don't have stability, if you don't have strong attachments, when you start to get into just day-to-day adversity, whether it's bullying at school if you're a little kid, or difficulty academically, say if you're trying to learn how to read, if a parent is not available to be able to give you support and encouragement during those periods of time, the child begins to then look for support elsewhere. Sometimes it's not exactly in the most constructive of places. And over time, this can sort of chip away at the development of a young person. Also, when you look at, for example, substance use in youth, typically the emotional development of the child is going to stall around the time that they begin to abuse substances. And so coping skills don't continue to mature. And so as they age, their chronological age, of course, will continue, but their developmental age is going to be underdeveloped. And that makes it much more difficult, for example, when you go to a workplace and you feel as though it may be stressful. How do you cope with that stress when you haven't really had the coping skills from your youth? And so the impact of substances and trauma on the life of a person, from whether it's an infant who has difficulty bonding with a parent, or a young person who has difficulty in a marriage because of communication issues, all of those things sort of come to a head, and the traumatic experiences make that even more so imperative that you have someone to be able to help guide you through, how do I solve these problems for myself? But the trauma, we see that a lot across the board for persons, for example, who come to us. Sometimes it's very hard to even get the person engaged to go to a therapist because they feel, whether it's embarrassed about a history of molestation or rape, it's very hard to get somebody to say, I have to face this in order to be able to improve the quality of my life. And so again, I mean, this is a topic that could take weeks to be able to discuss really and truly. Sometimes you could spend hours just on the impact of trauma at one point in a person's development, but it is quite significant.
Thank you, Dr. Cartwright, for that excellent explanation. I want to go to Dr. Petit, who works at a university that has been positioned to specifically address historical trauma among racial minorities as a historically Black institution. Can you speak to how your team thinks about trauma and perhaps even racial trauma as it relates to this issue?
Right. Well, recently we added a psychologist to our inpatient detox unit for this, because of this very issue. So my background is in internal medicine. So when I think about trauma, most of my patients that I come across, have suffered a significant amount of trauma. So I kind of did a deep dive into how does this lead to substance use and behavioral disturbances and so forth. And it seems like there are multiple articles out there that show that trauma, either childhood experiences or adult experiences, can lead to significant hypersensitivity in the hypothalamus pituitary axis. That makes it more difficult for these individuals without assistance and therapy and so forth to learn how to manage their stressful situations from a regular day in and day out, as well as they're more prone to suffer from depression. And it's been shown that individuals with trauma that have depression have higher levels of cortisol versus individuals with just that suffer from depression. So I think keeping that in mind kind of helps me get a better picture of the individual that I'm treating, and understand that the behaviors that I'm coming across aren't necessarily completely voluntary, that this is a disorder like any other disorder that has to be managed in a team effort. And that's where psychology, the peer recovery coaches I mentioned played a really big role. My patients tell me all the time that when they're having a crisis, they call their peer recovery coach and really helps them kind of talk through the situation and step away from it. And once that happens, they're able to actually learn from that experience and learn how to deal with stress instead of seeking substances as a way of managing their stress.
Thank you, Dr. Petit. And I noted that you highlighted the role of peers, and we should underscore that today. The role of individuals with lived experience to help other individuals who may have or be living through trauma. I want to go to Dr. Manalai and then Dr. Richards to conclude our thoughts specifically as it relates to trauma and substance use.
I think Dr. Cartwright is very right. Trauma has a significant part in substance use disorder. Actually, it is an independent risk factor for substance use. Trauma is an independent risk factor for future traumatization and substance use disorder. So it may be at the order of, for example, genetics. It's an independent risk factor for individuals to be in a situation that they may use substances and may get significant social problems. That's compounded by the fact that once they are using substances, it puts them at high risk for trauma. When they are traumatized, it is by itself a risk factor for future traumatization. Now they are using substances and it puts them in a vulnerable position. It creates a vicious cycle of further traumatization. If we think about it, Kessler, in his epidemiological studies, at least in one of the a very interesting paper, say about 70%, 70.4% of people at some point would experience trauma, and about almost 40% of those who are in sexual traumatized in some ways sexually, usually in female gender, but it could be in males as well. They develop PTSD, and PTSD puts them at risk for further traumatization, substance use, and this continuation of a vicious cycle. So if we look at it from that perspective, hopefully our treatments not only address the possibility of them getting off the substances, hopefully our treatment would be a little bit more holistic to consider the original sin that for some people results in patients using substances addressed. Hopefully we would have psychologists on our team, peer supports on our team, and address the trauma. And also, can we fix some of the automatic thinking that may not be so healthy? For example, fixing the relationships that can never be fixed. We go to the same traumatic relationship one after the other. Theoretically, we try to fix the thing we couldn't fix last time. If a psychology or some sort of therapeutic, psychotherapeutic approaches are employed, probably we could decrease that events. And also the interesting part about trauma is that most people do experience substantial relief after treatment. With the exception being war trauma tend to last much longer. Most other traumas, including the sexual abuse, they do receive substantial improvement after treatment, even within the first year. Of course, they remain vulnerable down the road. So not only understanding that trauma can predispose our patients to substance use, it may actually help us when we address it to reduce future traumatization and decrease the recurrence of the recidivism and pattern of inpatient hospitalization repeatedly.
Dr. Manilov, may I just piggyback on what Dr. Manilov just said? I think his example is a beautiful one, because when you think of what we are talking about, it seems so heavy and hopeless. But the point that he just made, for example, when you are able to assist someone and address these problems, let's use a specific example. If you have a mother and the mother is depressed, 50% of those children, including babies, end up with a similar diagnosis. The solution is to treat the mother, because the children will mirror what the mother does. And so in terms of being able to help the parents, you actually support the children within that family, and that will be able to help them to avoid becoming collateral damage to a traumatic experience that may have taken place with an older person or an adult inside the family. So there's a lot of benefit in being able to seek treatment.
Absolutely. And I see a lot of nods and amens coming from Dr. Richards. So Dr. Richards, jump in and tell us what you would add to this conversation.
Even before I do that, I have to piggyback now off of what Dr. Cartwright has said, because it's so important, and it's almost, if we take things back, I mean, certainly this is, we're talking about patients and what happens in our world, but this has been traced back to different animal models and everything else, with when we know if we treat mom's anxiety, the offspring actually improve. And so it's almost easier sometimes in other models. Humans have a harder time of figuring that out, but that is one of the key issues. And Dr. Petit has mentioned race and the role that race plays in this. And I would take it a step further to even say, there's so many other examples. We're still in this pandemic, and the CDC has published that either 13% of people have noted that either there's increased use of substances or they've started using substances during the pandemic. And so it really is our ability to help people cope with adversity. And traumas, of course, have to be addressed. And there's so many other issues that people are facing that with the right coping skills, with the right information, we may be able to steer them on a different path away from the substance use. And so that's one of the most important things that we have to identify, is what is the background, what's contributing to this trauma. and understanding that then allows us to move forward. But a lot of times people get stuck in trying to say, I don't have the trauma. You have to be able to understand that. But I also wanted to highlight the fact that we've talked a lot about different traumas, but we also have to, again, talk about treatment and how we address that. And what comes to mind when we talk about this is even sickle cell crisis. I mean, we'll hear time and time again from patients that are having crisis, and either it's fed to one, treating that pain has become an issue. And so collectively, again, talking with peers, talking with people who have addressed that, there's a need for even the providers to really understand not only the traumas, but what has created people in the moment that we're seeing them. And do we talk about substance use disorders? Do we talk about, I know we'll get into this, do we talk about pain and how we're going to help someone manage pain? But all of those things actually fit in together and are important in moving forward and addressing the reason for the substance use disorder.
Thank you, Dr. Richards, for getting us there, which is exactly where we're going next, is treatment. How do we provide the life-saving treatment that is needed for individuals who are dealing with the legacy that we acknowledged in our introduction, that the trust for medical providers has been eroded because of historical decisions. As we know, historically, there was a war on individuals with substance use disorder. And now we are transitioning into models of treatment and engagement. But many communities have been harmed who historically also needed to be rescued and treated. And so understanding that legacy and how it impacts those in greatest need. We know, someone in the chat is asking, what do we know about the demographics of those affected in DC? We know that they are predominantly African-American, in spite of the fact African-Americans are only 47% of DC's population. We see the same inequities when we see those affected by COVID-19. And so I want our panelists to just share with us, how do we engage communities specifically of color, those who are in greatest need with treatment? And let me go first to Dr. Petit.
Well, what we've been doing here is just really providing a lot of education. When they come into my office, the first question they ask me, why are you giving me one drug for another drug? This is just a way for you to, make money for the man, if you will. And so with that question, it opens up an opportunity for them to understand, what the whole idea is behind methadone or Suboxone, and so that they can appreciate the future of not having to wait on the street corner to buy something that they don't know where it's from. And only 4 to 6 hours later, they have to be out again to do the exact same thing. That methadone or Suboxone would help them normalize their life. That's something that they've never experienced for quite a long time, and allow them to spend most of their day doing other endeavors. So that's what I say half of my time during the clinic appointment is education. And I know we've got some outreach programs that our university is doing. We've been talking about putting together a bus as well to go out into the community. So basically, it's all about outreach and education.
Thank you, Dr. Petit. Dr. Cartwright, what would you add to that, especially with your lens, thinking about the whole family?
I will tell you, some of the best outcomes I see in terms of outpatient is being able to have a physician where you feel as though the person is relatable. Sometimes when we sit in the office, it's just to sit down and have coffee and to chat about what has your experience been with your spouse? What have you all argued about just last week? Mm-hmm. And so it may seem simplistic, but if you were able to get support and learn how to communicate better with that person because your mood is under control, because the antidepressant is working, it gives everybody a boost of encouragement. One of the things that I hear a lot is, I don't want to be stuck on your pills for the rest of my life. And my response, with all sincerity, is I am happy to kick you out of our office. When you are feeling better, once you stay on your medication and you are doing well, we are happy to see you go. What I mean when I say that is I try to educate them, for example, on the guidelines regarding the treatment and how long the duration of time, for example, would be for the treatment of depression if it's the first time the person is being treated, what the statistics will look like. 90% chance you don't have to come back here. But we always tell them we enjoy being invited to nice parties and weddings if ever you want us to celebrate with you. And so I think when people feel as though the physician is cheering for them, that the physician understands their perspective and it's not coming from a position of judgment. Because I have a conversation with you that your urine tox screen is positive does not mean that I'm being judgmental. I'm trying to at least figure out where is the start point for us and what do we have to do to get you to a place where you feel as though you can tolerate the stresses that you have and directly address the issues that you feel are contributing to those stressors or contributing to the behavior that you see that's negatively impacting your life. I will say though, for us, what we see at United Medical Center is unusual in that right now, and I did not see this before the pandemic, but right now, about a third to a half of the persons coming into our hospital, we have a positive urine drug screen for PCP. And so opiates are there, but for our population, it's unusual, but we see that about 30 to 50% of the time with admissions. And so being able to have a conversation that's not positioned from judgment, but let's look at what the options are and what will be some of the barriers for you to be able to address this when you leave. How can we help you? I think that people begin to realize, like, look, they really are trying to help me get my life back on track, and it may not be in the best place, but at least I can see that there's a step-by-step route that I can take to improve the quality of my life. And I always tell them, it may take a while, but it's worth it. It's worth it to be able to invest in yourself and see that things can get better. And you may have some bumps in the road, but our philosophy over at United Medical Center is every day is not going to be perfect. And it's okay if today is bad, but we can work toward tomorrow being a little bit easier. And that sort of normalizes expectations in terms of how long this process of getting better may take.
Thank you, Dr. Cartwright. Dr. Manalai, what would you say to the question of how we engage vulnerable communities in treatment?
I think my colleagues addressed some of them, but one major part is on our part, the systemic challenges we have in our educational system. I think both of us had similar experience of when I was at Howard University. Sometimes I would we will educate our students that, for example, schizophrenia is overdiagnosed in minorities. But once they are forced to make a choice between affective disorder and a primary psychotic disorder, it was my observation that our teaching did not have the desired outcome. When the students are forced to choose, they would pick up psychotic disorders more often for people of color compared to non-Hispanic white population. So there were a few times that patients would be almost identical. If you had covered the ethnicity, the presentation would be very similar. I think we should do a good job on our part to teach ourselves and our colleagues. I would give a very heartbreaking personal example. I worked in a facility and I was called for a consult to talk to a 21-year-old boy who attempted suicide by overdose on opiates. And as I'm walking in the emergency room, the emergency physician is leaving the room, and he, in front of this kid who literally barely cheated death, in front of the kid tells me, talk to this idiot, one of these days he will die. So I think we should do a little bit better job and also have a way to measure, do our interventions actually make a difference when it comes to systemic problems we have. Also recognizing that what are our specific challenges in a specific environment. For example, there's literature showing that different boroughs of New York have different challenges, like Dr. Cartwright mentioned that PCP is very prevalent drug in DC. It's in somehow, since it is a drug that unfortunately African Americans use, automatically we sometimes assume those patients are probably the worst patient you see. If you cross the river to Virginia, you don't see PCP that much. It doesn't mean that the patient who are in DC, they are worse off than the patient who are in Virginia. So we should customize our treatment approaches in a way that addresses the challenges we have as a system, as well as addresses the challenges that we have as localities.
Thank you, Dr. Manalai. Dr. Richards, what would you say in terms of recommendations for engaging individuals in treatment?
Right. So at Sibley, there are key changes that happened last year. One being we did introduce the role of the peer recovery specialist. And that has made a difference because the most important thing is, as has been said, letting people know that they're supported, that they're not being judged, but that there's hope and that we can lead them in the direction which we recommend, right? Starting them on medication-assisted treatment is important. Telling them, nope, it's not only while you're here, this is your next stop. Let me explain to you the roadmap for what's coming next. So that's important. And I think at Sibley, one of the important things is that we've seen this work. We've seen people really engage with others that they think they have a common bond with. Now, of course, that can be a peer. That also, last year in 2020, with some colleagues from Hopkins, we published the fact that minorities are underrepresented in psychiatry. And it's across the board. It's as providing psychiatric care, it's providing therapy. And so there are a couple things. Sure, there's a push because a lot of times people do want to have a bond. A lot of times what they're seeing is the first things that you look at: race, gender identity, cultural, those sorts of things. But when that's not there, and it's not always going to be there, the other thing we can do to support them is learn, is understand, is ask, well, why is that important to you? What is the barrier? Why can't you get to that clinic? What happened when you took that medication? And then being able to say, okay, I think I get it. Let's try this, but really engaging the person in as part of the treatment team. And one of the first things I say is, look, you're part of this team. I can't tell you you have to do X or Y or Z. Let's talk about this plan, ask me the questions, and let's see how we can move forward together.
Thank you, panelists. And we want to transition and acknowledge the excellent questions in our chat. Dr. Richards, I'm actually going to go to you first because you mentioned something that is actually in the chat. One individual has asked, what do we do about the shortage of providers, specifically those who can engage? And as you mentioned, often individuals are looking for concordance between their providers and themselves. And so what is the panel's outlook on the shortage of providers and how do we address the shortage?
I think we need to sound the alarm. It's really important that we pull people into this field. In Dr. Petit's case, we see that specifically when we talk about addiction medicine fellowships, that again, and even in that realm, underrepresented minorities are not going into these fields. So there's twofold. There's a shortage of providers across the board, and there's a lack of ongoing gender, which is improving, and race concordance. And so one of the things that we need to do is find ways that we can pull people back into this field. And it starts early. It starts in high school with different programs. It starts in medical school. A lot of times the medical schools had options to say, well, can you join this group that's talking about psychiatry, that's talking about substance use disorders? And so we have to get more vocal about why this is an important field, and then find ways, right? There are ways, there are grants, there are other options to encourage specialists, both medical specialists, therapists who can provide additional support to encourage them to really join us, in this role.
And one thing I would add to that is we have a need that is quite significant. I think that we may have to appeal to Congress to perhaps expand the number of residency spots for medical students to be able to enter into psychiatric training, because this area is very, very important. I think it's a beautiful thing to have a psychiatrist available if your child is in a difficult situation and to know that they are in well-trained hands. And so I think to my understanding, there were very few, maybe 4 residency spots that were unmatched this year. But when you take a look at the impact that the pandemic has had on the population, I have had people get very, very frustrated, like, well, Dr. Card, why can't we get another appointment? And our office is working 7 days a week, some days until 9 p.m. And so it's not that we are not trying, there's a need. And I think that in order to be able to truly address that, we have to have additional physicians trained. So the number of residency spots, I would suggest that they need to be expanded. It's really, really important for the health of the country as a whole.
And I would agree with that.
Loan forgiveness. They could easily give loan forgiveness as well. I mean, there are ways to pull people into these fields, and we just need to activate them.
But just to piggyback on what Dr. Cartwright said, I think it would be a very wise advice to increase the residency spot. We usually go for the low-hanging fruit, and not always it pays off what we want them. For example, nowadays, I don't mean in a demeaning way. I appreciate the opportunity for some of our nursing colleagues to become nurse practitioners, but sometimes the disadvantaged people who don't have, whose care is complicated already, and then you provide them with someone who has less than adequate experience and expertise to care for them. One, their care is complicated, and then the person who provides care, I'm trying not to sound in any way pessimistic or demeaning to anyone, but you provide them with an expertise that is less than adequate. So I would agree with Dr. Cartwright, probably instead of kind of cutting corners and going for shortcut and low-hanging fruits, let's invest as a society to increase the number of residency spots, increase number of training. For example, addiction medicine fellowship. If it is incentivized, I'm pretty sure more internists and primary care providers would jump on it. For example, if the salary is a little bit high, provided some incentive that could make it a little bit more appealing. Why would they spend 1 year more in training, providing care that no one likes those people? I'm saying those people in quotation, so that people who struggle with addiction, as a general, I think it may be a little bit of a fact that most clinicians don't like working with them. Can we remove that stigma from there to see if more people could jump on board and more people would be available to provide competent care? Meanwhile, it is a good idea to continue with nurse practitioner, but I would absolutely wholeheartedly support Dr. Cartwright's call that we need more residents.
Thank you, Dr. Manalai, and want to also share with our guests today that during the pandemic, we also learned that we can also do the work a little differently. We learned that we could provide care through phone calls. We learned that we can do this without standard office visits, and many providers are pushing and advocating that these mandates that happened at a federal level with the DEA would remain even after the pandemic. And so we have to think about what we learned throughout 2020. I know myself as an addiction medicine provider, even caring for individuals experiencing homelessness, it was amazing to see how our system just evolved to care for individuals who only had a phone. And that was incredible to see. So we are advocating for a lot of those changes to remain. I want to go to another question in the chat. This also has something to do with provider capacity. The question is, very rarely do I see individuals who are prescribed substance use disorder treatment linked to a therapist. Isn't this counterproductive? I want to go to you, Dr. Cartwright, to tackle that question. What is the role of a therapist in care? How can we improve their integration in the care team?
I think therapists are very, very important, and therapy in general is very important for anybody who is also receiving substance abuse care or substance abuse treatment medications. But right now in the pandemic, there is a large shortage of therapists just because so many people are stressed by the experience of the pandemic. One of the things that we try to do in the outpatient practice is to, even if we can't assign the person to a therapist, we can still have brief sessions during the period of time that we meet. If the session goes for 30 minutes, for example, we can still touch on their medications, make sure they're doing okay, and just talk about, how are you? How are you doing? What are you planning to do to get past the fact that you've been stuck in your house for a week and you are lonely? Do you plan to go on dates? You'd be surprised. Like, these things seem very simplistic, but for a person, for example, in their mid-30s who is interested in meeting someone who wants to start a family, like, this pandemic has really been, it's been terrible for different people for different reasons. And so you can still provide brief supportive therapy sessions during the period of time that you also check on medication. And then, of course, when we finish up with one patient, we always try to place another patient on for therapy. I do think that therapy, in terms of being able to process, why am I turning to this particular substance? What am I getting from this? What progress have I seen for myself? Being able to put those things in the forefront of your mind reminds you that you're making progress. It may not be perfect. And I think that that's a part of the role of the therapist in conjunction with medication. Again, it may not be ideal the way it was prior to the pandemic when the demand was not as high, but we can still accommodate those persons. And I think that many places really are doing their best, trying to be as flexible as they can with scheduling.
Thank you, Dr. Cartwright. Want to pose this question next. Someone has asked, let's contextualize this specifically to the District of Columbia. And of course, I did share my understanding of the latest demographics, but they want to know specifically, what are the unique differences in terms of demographics or treatment challenges when we look at DC? Who would like to tackle that one?
I will.
Okay.
So again, on our side over at United Medical Center, I'll tell you some of what we see. The use of the polysubstance use has gone up since the pandemic. Sometimes, for example, we will see at least marijuana, PCP in conjunction with something else. And that has increased drastically to the point where I was really struck by it, because as the pandemic has continued, I see it more frequently. We have a large number of African-American persons who come through our doors at United Medical Center, and also the trends that we notice when we offer substance abuse programs when it's time for the person to be discharged or get in preparation for that. Many persons have similar concerns. I can't take time off work because I've had to miss so much work because of the impact that the pandemic had on finances for my family prior to being able to get back to work. And so they are worried about, how am I going to maintain myself financially if I go to a substance abuse program? Then some of the programs had restrictions on the number of persons they would be able to take, because you were trying to make sure you don't expose people to coronavirus. And so logistically, that also played a part in how many people would be able to receive care on an inpatient basis. One final thing that I noticed, but I find that this tends to be unspoken, is there's dignity and pride at stake as well, where there tends to be a lot of embarrassment. Sometimes people will be in complete denial and say, no, I didn't use any substances. And the question is, at the time when we only have a limited number of days in the hospital, how do I approach that conversation with you so that you see it's not about judgment? We are trying to get you to a place where you can address this and feel like your life has more stability. How do we do that in a gracious way? Because all of us have pride that we want people to respect, and all of us have a sense of dignity that we want other people to acknowledge in terms of how they treat us. And so we have to be able to choose our words carefully so that folks who already have had difficulty even coming into the hospital because the police had to bring you, or your mind was not clear and you didn't have your clothes on and now you just feel completely embarrassed and vulnerable. How do we still acknowledge the humanity of that person, treat them well, and say, look, that's water under the bridge. We have to get past that and try to make sure that we figure out how to make tomorrow better. So those are the trends that we see in terms of use, and some of the barriers that we see that people are thinking about when they try to figure out what their next steps will be when they are discharged from us.
If I could piggyback on that for a second. if I could piggyback on that for a second, I think we should look at the specific population, specific challenges, and specific opportunities when we work in the District of Columbia. A few years ago, we looked at our patient populations. Over 10 years, one of our colleagues, Dr. Lawson, had provided Suboxone, and we look at the patients that had been adherent, and we defined adherence as 80% compliance. What would be predictor of adherence in our patient population? Some of the things are surprising, like we were surprised that nothing was significantly associated with adherence except for alcohol and cocaine use. Later on, we looked at another problem that was emerging at the time, the K2 use. Is there anything that can be helpful identifying who is at risk for K2 use? It doesn't seem like there's any particular thing that would put a person at risk for K2 use. We thought probably since K2 is quote unquote similar to marijuana use would predict what K2 use, predict who might use the synthetic cannabinoids, the most commonly known substance is K2, which is not really a substance, a whole bunch of substances. So I think Dr. Putit and the people in education component of the District of Columbia can play a role to find what are our specific challenges, and that would open up a window for us. What would be our specific intervention that could address the needs of our population in District of Columbia? A perfect example would be, as Dr. Carter said, PCP use. PCP is very common in our region, but not in, for example, I don't know other localities, but not in Virginia.
Thank you, Dr. Manalai. We are unfortunately out of time. And I want to thank everyone for participating today. I want to also acknowledge the critical comment in the chat. You are absolutely correct, Ms. Lightfoot, that in the context of the many needs that exist, we can absolutely use peer providers to fill in the gap. Thank you for that reminder. We all have a work to do in the spectrum of care. And so let's keep at it. We've talked about reforms today that are needed in the system. We've talked about how we can engage patients. I liked how we started framing it from a person's life story with Dr. Richards and her perspective. And so thank you, panelists, for your participation today. And now I want to transition to Ms. Cunningham to close us out. Thank you.
Thank you so much, Dr. Medlock, and thank you to all of our panelists. Your expertise is just so helpful for us to have these conversations and make sure that the important topics that we discussed today do not go overlooked when we're trying to treat SUD patients and behavioral health patients. So really appreciate you taking the time to speak with us today.